Hello, this is Catherine Poole, President and Founder of the Melanoma International Foundation, welcoming you to a wonderful webinar today. Today we have Jeff Infante, Director of Drug Development at Sarah Cannon, and he is one of MIF's board members. His time is very limited today, so our questions are going to start out the webinar instead of being at the end of the webinar. So I'm going to just ask two questions of Jeff and then let him go with his show. The first question that we received from a patient is the sequential better than the simultaneous when you're doing immunotherapies? Side effect-wise, is it better to go with sequential? I think, we're talking about IPI and PD1 better than having them going on simultaneously because of side effects. And you can answer that later on. The second question is there any indication that immunotherapy can later set the stage to enhance another therapy that comes down the line?
Okay.
And that's pretty much it. So.
All right, I will try to answer those throughout the course of the talk, because I do think I have some slides that explain some of that.
Wonderful. Thanks again, Jeff, for your time, and I'm looking forward to your slideshow.
Okay, thank you. All right, thank you. Again, this is Jeff Infante, and I'm Director of Drug Development here at Sarah Cannon in Nashville. And Catherine asked me to give a talk after ASCO on combination strategies, and I thought this would be a good time to give update. As she's already mentioned, there's a lot of focus on combinations of both immune therapies and targeted therapies. And so I'm going to kind of start the slide set. And on the left-hand side of this slide, as Director of Drug Development, this is how we think of our program of bringing in different drugs that target cancer. And this is an old figure from Hanahan and Weinberg back in 2000. And these are kind of 6 major principles of how cancers grow and evade the immune system and kind of are able to continue to grow, but not interestingly on these 6 back in 2000 that were identified, the immune system wasn't directly in there, and neither were genetic mutations. And so these hallmarks of cancer have now been updated as it's clearly becoming evident, and on the pink side that avoiding immune destruction is clearly important, and genome instability and mutations are clearly important in ways that we can design therapies and then help patients in so doing if the therapies work clinically. And so I think melanoma research in general has been leading the way in that area. And so we'll focus the majority of the talk today on combination strategies, on targeted therapies, and then combination strategies with immune therapies, and then to kind of end on future directions. So I put this picture in here because I kept the theme of the talk as evolution. I think we are evolving both as oncologists, but the whole field of truthfully oncology is evolving, and we're changing rapidly, and hopefully the changes that are being made will dramatically impact patients in a similar fashion, and I think we've seen a lot of that over the last few years. So first, starting with the targeted therapies, this is a pie chart of the genetic alterations in melanoma, and the most focus has been on BRAF, and about half the patients have a BRAF mutations, but there are other mutations that can be identified, and these are not normally inherited mutations. These are acquired mutations that happen at some point in the cell, but often lead it to have some type of malignant potential. The second most common one is NRAS, and then we've also I've identified KIT abnormalities, GNAQ and GNA11, particularly in ocular or eye melanomas, and then there's MEK and other abnormalities that are being identified. And I think more and more driver mutations will eventually be identified. But the promise is that if we can match therapies with these specific genetic alterations within a patient's tumor, that we could have dramatic clinical benefit, and that drugs will likely to be developed in very specific or niche indications, and they'll have to be companion diagnostics so that you can identify the right patients and then be able to match them with the right therapy. And again, melanoma's led the way here with the BRAF inhibitors, and this was data we've shown with Catherine a year ago, looking at Vemurafenib, the selective BRAF inhibitor, which was initially developed by Plexicon, and then now with Genentech Roche, showing that on progression-free survival, it clearly is better than standard chemotherapy with dacarbazine on these progression-free survival curves. But I think it also highlights the problem with targeted therapy to date, is that nearly all patients respond when they get this, and it's very rewarding as a clinician to give it to patients, because if they had a cough, it gets better. If they feel fatigued or weak, they tend to start feeling stronger. If they have pain, it goes away. The problem's been that the duration or the durability of the response is less than what we would want as oncologists, and most patients progress at some point. If you look at the median, it's around 6 months. So, I think a lot of effort is ongoing trying to understand that, and this is kind of a slide I've used to set the stage that I think most of us feel that you're going to need combination therapy to have dramatic success. And my favorite person to think of with this is Magic Johnson. When I was in high school, he was definitely a hero for a lot of Americans. And, I remember the day when he did the press conference and had the announced he had HIV, and, at that time it was considered a death sentence. But, he's still on TV shows. He looks great. He's announcing for games. So, I mean, the evolution of HIV therapy is something that I think as oncologists we should try to model for oncologic therapy. And this is a population data curve showing that prior and HART is the triple combination therapy that's used for HIV patients, but showing that prior to that, it was a very poor prognosis, and then the patients were dying very young. And then when they had early HART, which was usually single or 1 or 2 drugs, that we did better. But when they finally got to the later stage of HART, which is now considered what's standard, which is multi-drug therapy, that you can have survival curves that are near what the population is. So I think this is where oncology is moving, and the first step in that was the combination of BRAF and MEK, so that you would give a selective BRAF inhibitor. In this case, it's Dabrafenib instead of Vemurafenib, but they're very similar selective BRAF inhibitors that work well by themselves, with, again, about half the patients having confirmed responses. And then to give it with a MEK inhibitor, which is downstream of BRAF and BRAF signals through. And MEK is often overexpressed when you, as a mechanism of resistance, when you give a BRAF inhibitor, so that if you could give both these drugs together, that you would delay the BRAF inhibitor resistance, and you could also decrease some of the side effects, such as the hyperproliferative skin lesions that were associated with the BRAF inhibitor. And so we myself and a bunch of other authors and sites, we worked on this trial and eventually published it in the New England Journal, showing that if you, in the green curves here, again, this is progression-free survival curves, and the green curves are if you're able to give both BRAF and MEK at their full monotherapy doses, that you do better than if you give BRAF at its full dose with MEK at a kind of an in-between dose versus the BRAF inhibitor alone. And so this suggests that the combination strategy for targeted therapy is definitely a step in the right direction. And you do have some increased toxicity when you start adding drugs together. In this case, we had fevers and chills. I think oncologists are better at managing that. We can use different Tylenol, ibuprofen, and other antiemetics, and occasionally need to use steroids. The interesting finding was the rash that is associated with MEK inhibitors is very common. Around 80% is much less in combination, and that's still being worked out as to why that is, but it's one of the few times where we've given 2 drugs and some of the side effects actually improved. And rash was one, and then the hyperproliferative skin lesions that are associated with BRAF inhibitors still occur when you give the combination, but it looks to be less than if you're giving a BRAF inhibitor alone. So, I do think there's a lot of still focus for targeted therapy with the combination of BRAF and MEK. This is a complicated figure that was presented at ASCO by Dr. Saussman, but the top 2 curves are if you had never had a BRAF inhibitor before, and this is the progression-free survival, and that matches what we had presented. But if you're looking at the yellow and the blue curves, these are patients that had already had the BRAF inhibitor and then had the combination. They either came on after having a prior BRAF inhibitor, or they were actually rolled over upon progression of the monotherapy. And you can see there are a few patients that do well and do gain benefit from the combination, but it doesn't salvage as many people as we would want if you add the combination on later. So there is kind of some movement thinking that if we're going to use the combination, you may want to move it up front, but that's not solidified at this point. So I'm a big fan of combinations. I mean, I think with the BRAF, I like this whack-a-mole figure where you have the oncologist and we see a BRAF mutation, we give a single drug as a selective BRAF inhibitor, we knock it down, and then other things just pop up, and it gets frustrating. You can only do that so much without wanting to whack yourself because you get frustrated. I mean, we're just trying to do whatever we can to stop these cancers from growing. And so this was an interesting study that we're participating in, trying to come up with other ways of thinking about resistance. And so that, again, since most patients are going to respond to a BRAF inhibitor, if you take a patient that has a BRAF mutation and you give them a selective BRAF inhibitor, and then we would biopsy if needed at the time if the BRAF inhibitor stops working and the cancer starts growing. Because there are a few patients that stay on the BRAF inhibitor for many, many years, but the majority will progress at some point. And when they do, if we were able to do a biopsy and then send that tumor biopsy off and identify the mechanism of resistance of why, and then be able to place them on the exact combination trial which matched up to their particular tumor. And so this is a trial trying to do that after you would biopsy, if the BRAF inhibitor wasn't working, if MEK was overexpressed, you'd go on a BRAF-MEK combination. If the PI3K pathway is overexpressed, you'd go on a BRAF PI3K combination, and the same for FGF, MET, and CDK4/6. So this is kind of a logical way of trying to assess resistance at the bedside in the clinic and then be able to direct combination therapy for those who need it. So I'm going to move on at this point to looking more at immunotherapy, and I think this was published by Antonio Ribas in Clinical Cancer Research, and I like from a schematic thinking about fundamental principles of why immune therapy has such a strong presence in melanoma and now moving into other tumors, is that I showed you the curves of Vemurafenib versus chemo, and it looked very similar to this, that if you have a standard progression-free survival curve or overall survival, that when you give a targeted therapy, we can move the bar and we can make that better, but still the line comes down and eventually comes close to meeting up with what would normally happen, and that means that most patients are progressing at this point, and there's really no tail to the curve. And the difference has been with immune therapies is that if you get on the right immune therapy and you're one of the patients that the immune therapy works, you can get prolonged benefit with very durable responses, and so there becomes a tail on the curve. And so there's a lot of focus on how do we move this tail of the curve up further so we're benefiting more and more patients. And I think the whole concept of immunotherapy comes from the philosophy that the cancer system, or cancers in general, should be recognized by the immune systems, that tumors express certain antigens, and the immune system should be surveying for these antigens, and then when they recognize that a cell is abnormal and has become a tumor, that it should recognize it and eliminate it. And at some point, immune tolerance has happened, and that These tumors have multiple mechanisms to evade the immune system, and they express molecules that inhibit the immune response, and then your infection-fighting cells or your T cells become exhausted against the cancer, and they aren't able to fight it off, and it becomes similar to like chronic hepatitis situations for patients that have hepatitis C, where you kind of get this immune system burnout, and then it's not able to fight the cancer. So the whole goal is if you could get the immune system to start seeing the cancer again, it could be a very effective treatment strategy. And so this pictorial shows an antigen-presenting cell with a infection-fighting cell, and these antigen-presenting cells are designed to pick up pieces or antigens of tumor here in brown and then present them to your infection-fighting cells. But in so doing, for this infection-fighting cell or T cell to become active against or activated, it needs a second signal to become activated, and it's called a co-stimulation signal. And so there are both positive and negative second signals, and some of them activate the immune response and some of them inhibit the immune response. And this is the focus of drug development in immune therapy right now, targeting these co-stimulation or the second signals. The first one was CTLA-4 blockade, and again, the drug that's FDA approved is Ipilimumab, and this is a fully human monoclonal antibody. In this pictorial, the T cell or your infection-fighting cell is in yellow and the tumor cell is in blue. The antibody binds to CTLA-4, which is a negative co-stimulatory receptor on the T cell, and this drug was approved in March of 2011. And sorry, the animation didn't work here, but these were the overall survival curves that got Ipilimumab or the CTLA-4 inhibitor approved, and you can see what I was explaining, that there's a tail on the end of the curve, that there's a certain percent of patients that this is a very effective drug for, and that they survive for many years after taking the therapy. And so to me, the treatment paradox has been you treat a lot of patients and you only help a few, because the majority of these patients, if you look at the way these curves are, there's still 4 out of 5 or so patients that the drugs do not work for. And then the few you help, if you do help them, you help them a lot. And so they stay, you can see that there's patients alive with metastatic or advanced disease for many, many years. And so one of the other issues with CTLA-4 blockade has been that you treat a lot and you still hurt a few, right? Because maybe you turn on the immune system a little too much, and instead of having a campfire, you have a forest fire. And the most troublesome adverse event has been colitis. Even though diarrhea is frequent, severe diarrhea is not that common, but when it is common, or when it does happen, it can be very severe for patients and can require a lot of other therapies to try to quell it. You can get other flares of your immune system against yourself, including dermatitis. You can get endocrine abnormalities or hormone. These are kind of hormone-type abnormalities, eye abnormalities, liver toxicity. So once the immune system gets turned on too much, it can be harmful. And right now we have an inability to predict who you will help. So you can't identify these patients down here, and you also can't identify the patients who you're going to hurt with some of the severe toxicities. And I think oncology is trying to move in a better direction there. So what else do we have besides the CTLA-4 inhibitors? For the last 2 years at our national meeting, a large focus has been on PD1 inhibitors, and PD1 inhibitors, you can have an antibody that binds, this is a co-stimulatory signal also, on your T cells or your infection-fighting cells, and you can block the receptor of that just like you do with Ipilimumab, but this time to the PD1 inhibitor. And the first presented drug of this class of PD1 blockade was Nivolumab. And this is the median overall survival that was presented in 2012 with a 1-year survival rate of around 60%, and then at 2 years around 40%. So it looks like that we're getting that tail on the curve, and potentially may be better than Ipilimumab. The important things to take home from this, I think, with immune therapy, your memory response. So we think about kids that get vaccines and they have, you get vaccinated and you create memory antibodies so that if you ever get re-exposed to infections, that you have an immune response there to fight it off. And so you get, even after you stop taking some of these medicines, you likely have trained your memory of this, and that it still works even after therapy can be discontinued. And it's probably true that tumors are evolving in the face of immune therapy, but one of the great things, just like it does in the face of a BRAF inhibitor, but one of the great things about if you can redirect the immune response against the cancer, it likely is also evolving and adapting. Again, getting back to the theme of the talk, this immune system's allowed to evolve against the changes that the tumor's ongoing and to continue to fight it off, and likely contributing to the durable responses that we see in the clinic. So this is a second PD1 inhibitor from Merck, MK3475, and data from this was presented at this compound was presented at ASCO and then immediately published in the New England Journal. And this is a waterfall plot showing response. The way you read these waterfall plots, if the numbers are going up, then the tumors are growing. If they're going down, they're shrinking. And this one is color-coded, doesn't show up perfectly by whether patients had ipilimumab in the past or naive. And so there's a question about sequential treatment of giving a PD1 after ipilimumab, and it does work, and you can see it's kind of scattered. It doesn't appear to be different whether you had ipilimumab first or you have not had ipilimumab, that you still have good activity against the cancer. In this study, 38% of patients had objective response, looking at two different schedules of the PD1 inhibitor. From a tolerability standpoint, you still get some of the autoimmune side effects. You have fatigue, rash, itching, diarrhea, myalgias. So these aren't vitamins, but I'd say in general they feel, and as a clinician, as an oncologist, they feel like they're better tolerated than the CTLA-4 inhibitors, and you tend to have less of the severity of the adverse events. So I've described antibodies against CTLA-4. There's also, and then I just talked about antibodies against the PD1 receptor, but instead of blocking on the T cell side, you could also make antibodies that block the ligand, which is expressed on the tumor side. And so there are antibodies in development which target the PD ligand. And this is it's not labeled on here, but this is the PD ligand inhibitor from Genentech, looking at melanoma patients that received their PD-L1 inhibitor, and the response rate in this small study was about 30%, and then at 6 months they had 43% of patients were still on study without progression. And so also looks to be very active if you target the ligand, as compared to targeting the receptor. So both ways look to be promising strategies in melanoma. And if you look at what is the expression of PD-L1 on patients' tumors, the idea is, could you select the right patients for the PD-1 inhibitors based off expression of the ligand? And this is what an IHC, if you took a tumor biopsy and stained it for the PD ligand on the tumor, if it stains kind of this rusty color, that means the membrane staining for what you're checking for. And so these tumor cells express the IHC expression of the PD-L1 antigen, and that hopefully by doing that you could select out patients that would be more likely to respond to an inhibitor that is targeting such expression. And so if you're looking across melanoma, it's about 40% or so of patients, at least in this small sample, that express the PD ligand. So it's not quite half, but close to half the patients do express it on their tumor blocks. And then the initial study, which I had showed you with Nivolumab, had looked at patients that were PD-L1 positive by IHC as compared to those that did not express it on their tumors. And it looked like initially that if you did not express it, you didn't respond at all, and if you do express it, you were the one to get all the benefit. But now there's been subsequent studies with Nivo, and then this is the Genentech PD ligand inhibitor, and another study with Nivo showing that, yes, if you express PD-L1, you're more likely to respond, but if you do not, then there is still patients, and it's probably in the 20% range, that still respond to the PD-1 inhibitor. So PD-L1 expression is being looked at as a patient selection strategy, but there are patients who don't express it that still respond, so it's not the end-all, be-all, and other factors are likely in play that are being worked out kind of as we speak. So I think the PD1 pathway, in summary, especially from a toxicity standpoint compared to ipilimumab, you have similar immune-related adverse events, but you have significantly less grade 3, 4 or severity of the toxicity. Specifically, the diarrhea is improved, and you have fewer patients requiring steroids, hospitalizations, and discontinuations. There is a couple ongoing trials trying to get PD1 inhibitors approved. This is the one with the Merck compound, looking at 2 different schedules of the Merck compound versus ipilimumab. So I'm hopeful that in the next few years that these will be available by all oncologists around the country. One of the major questions with immune therapy in general and the PD1 inhibitors is how long do you give them? And this is an unanswered question. This is, kind of a schematic put together looking at, let's say it's a PD1 or PD ligand inhibitor A, B, C, and D, and I'm just making those up, but do you give a patient it for 6 months? Do you need to treat for 12 months? Do you need to treat for 2 years? Do you need to treat for indefinite, right? It's because, and that you kind of keep on some type of maintenance phase. And this is a very unanswered question. Obviously, the longer you stay on these drugs, the more worrisome you feel that as a treating physician that you could get an immune flare-up and create severe toxicity. And obviously for healthcare, financial dollars for the whole country, treating someone for a year versus 2 or more years can be very costly. So these are important questions that I think will unfold over the next couple of years. Lastly, I want to talk about the combinations with the PD1 and the CTLA-4 inhibitors. In this case, you're giving both the CTLA-4 and a PD1 receptor inhibitor, and as was mentioned by one of the questions, when you give the combination, you definitely have a lot of toxicity. If you look at skin tox, it's in the 70% range. It's either rash or itching, and if you look at diarrhea, it's in the 30 to 40% range. And if you get and you can get more liver toxicity or transaminitis, which are elevation in liver enzymes, and amylase and lipase elevations. So it's definitely not free of disease. And if you look at all patients that had a grade 3, 4 tox, and that's usually one enough to hold drug, it's about 50%. So it's definitely more toxicity by giving it in combination. But the reason to give it in combination is shown on this slide, and it's complicated. But here is the waterfall plot again, and so each bar represents an individual patient. This was presented at ASCO. And you can see there are patients whose tumors continue to grow despite being on the combination, so it's not the right therapy for them. But there are many patients that have decreases in their tumor volume, and in many that beyond that had very significant decreases. So this dotted line is at the 80% decrease in their tumor volume. So many with either 80% to near 100% decrease in the size of their tumor. So this is a very dramatic radiographic responses, and this is another way of showing the same data for patients that received the Nivo at this dose with IPI of 3, which would be the standard dosing. There's a few patients on these spider plots. This is time on the x-axis in weeks, and if you're going up, the tumors are growing at the different time points. If you're going, so again, the drugs are not right for these particular patients, but there are many who have a minor response and are able to stay on study, but then this dramatic decrease in many patients that have near complete response to the drug. And this looks like figures when we give, as oncologists, give treatment for like lymphoma, and you have complete response rates, which eventually can lead to cures, hopefully. So that's where people are getting very excited about the combination, that this response rate, when you're looking at patients that have 80% reduction in their tumor volume, when you give it in combination, is 40%, where with each drug alone, that type of response has been very rare. So that's the rationale for the combination. I'm going to go back one. To answer the question about sequential, there's definitely data saying that if you had a prior ipilimumab and then you add a PD1 inhibitor, you still respond. And so, I do think that there's no one right answer on this, on the best way to go. The rationale for the combination would be that, hopefully that we these dramatic responses turn into more patients achieving longer durability of response. So this is the trial for the combination that's ongoing. This is a phase 3 trial where you take patients that have not been treated, you randomize them to 3 different arms, and they either get Nivolumab alone, which is the PD1 inhibitor, or they get IPI alone, which is the CTLA-4 inhibitor, and this was the control arm, and then, or they get the combination. And this is a blinded study, so it's very difficult to explain to patients because the doctor's blinded, the patients are blinded. It has a complicated schedule, but it will answer a very important question, whether the PD1 is better than IPI, but also whether the combination is better than IPI or either one by itself. So I think where the future is going is going to be continued combinations. Whether it's CTLA-4 or PD1 is the backbone, where there's a lot of combination trials currently ongoing, and we have some of these here in our trial unit, looking at combinations with other co-inhibitory molecules, other co-stimulatory, so these are positive molecules to upregulate the immune system. So both strategies are ongoing. There's combinations with the kinase inhibitors or the targeted therapies like BRIM3, and then there's studies with chemotherapy, especially in other tumors outside of melanoma, and then combinations with other vaccines or other immune checkpoints. So a lot of activity as far as trying to really move the needle and make outcomes better for patients. I think things were off to the races, and the first thing was to do, and this title's wrong, it should be IPI with PD1 or CTLA-4 in CTLA-4 and kinases. That there's a very rapid study to look at Ipilimumab in combination with Vemurafenib, and I love Lee Corso in college football, and I love when he raises his pencil and says, "Not so fast, my friends." As we saw that in the publication earlier this year, that you get liver toxicity very quickly in some patients, and this halted that trial. So you can't just throw these drugs together and think that everything is going to work out and we're going to improve things for patients. You really have to do it in rigid, formal clinical trials. But the hope is that, if we look at these survival curves where you get this tail in the curve with Ipilimumab, and then hopefully it's better with the PD1 inhibitors, and maybe combination strategies will be even better, and that we keep moving the bar and moving the tail of that curve up so that we can take patients that have very advanced disease and really offer them hope that we can keep their disease under control for many, many years. And so in summary, I'll just kind of run through the things that I was thinking about going through the talk. There's 4 FDA-approved therapies now in advanced melanoma, 1 immune therapy, Ipilimumab, and then 3 targeted agents. 2 of them are BRAF inhibitors and a MEK inhibitor. I think this is fantastic. Looking back at 3 and 4 years ago, we didn't have any, so there's been a huge push in new drugs for patients with melanoma, which is great. With monotherapy BRAF inhibitors, I think they're great in what they are. Nearly all patients respond. The problem for both the patient and the oncologist is a frustration with the duration of response. It's just often not long enough. There's a lot of activity looking at combination strategies of targeted therapies. I think BRAF and MEK are leading the way on that, and it looks like it may be better than BRAF alone. The final data's not been presented yet on the phase 3 trial. I do expect other combinations as mechanisms of resistance in melanoma become more clearly defined. As far as the immune therapies, CTLA-4 inhibition is the tip of the immune therapy iceberg. I mean, that is the first drug approved, but the PD1 inhibitors are definitely taking a strong presence in the clinic, and you can target either the PD1 receptor or the PD1 ligand. And then there's the combination of PD1 with CTLA-4, and though it does have significant toxicities, half the patients have a grade 3/4 AE, the responses appear more frequent, and definitely there's patients that have very dramatic responses. And then lastly, again, here, even with immune therapy, combination strategies do appear to be the future for both targeted and immune therapies, and expect for these drugs to have early movement into the adjuvant setting. And with that, I'll wrap up, and with my evolution slide, melanoma therapy is evolving rapidly. The animation got messed up on here. My daughter, who's 8 years old, looked at this and asked where the woman was. So there's supposed to be a woman that pops in on this, and she's very observant to recognize that, and she's probably right. I have three girls, so I may be biased. In either case, this is my staff, and I wanted to thank them immensely. Cassie's in the room here who helped me put all the slides together. I could not do what I do without the staff that we have. We have over 75 employees dedicated to help our unit run efficiently and really try to bring new therapies in for patients as fast as we can and get these new therapies out so that we can start benefiting patients. And with that, I'll go ahead and end and say thank you to all the patients that are on the phone or family members. It's amazing what patients and family members go through just for the experience of dealing with cancer, and then especially from the trial side, they're so rigid and getting back and forth and the times you have to do things. It really is unbelievable, and I applaud you. And Catherine, with that, I'll end.
Okay, Jeff, just one more question that could I ask you?
Yes.
So if you were a perfectly naive patient of not having any therapies and you were stage 4, which would you start, and you were BRAF positive?
Right. That's a tough question. I think every day at the bedside I get that question, and it depends, right? I think I have that discussion with patients, and on each case it's an individual way to go. There's not a cookbook recipe how to go forward. I think if you have very limited disease and the pace of the disease does not appear to be one that's very rapid, then moving forward with into a trial like the combination trial versus PD1 versus IPI is very reasonable, even if you have a BRAF mutation. In theory, at least with the CTLA-4 inhibitors, the time frame to have a clinical response could take up to 6 to 9 months. So for patients that have very rapid disease, that may not be the best option, though the combination of the PD1 and IPI does look like responses are happening much faster, more like the kinases. So there's no one answer on that. It's kind of an individual discussion.
And then the other issue is, the MEK and BRAF were approved separately and not together as combinations. So patients...
That's right. Right now they're approved separately. I do believe that it's been filed with the FDA.
Yeah.
I'm not sure when they'll weigh in, but I expect it to be probably early 2014, somewhere in that time frame.
So possibly docs could go ahead and then just prescribe anyway.
Yeah, I don't know if that's being done or not. There's still some ongoing trials with the Vemurafenib plus MEK combinations out there and other combinations, so that I don't know how that's going.
Yeah. Okay. Well, thank you so much for all of your hard work for melanoma patients and for working with MIF, and we really appreciate all that you do and all the people that help you.
All right. Thank you so much. Thank you. God bless.
Thank you. Bye-bye.